I would like to introduce my mentor, Dr. Anand Balasubramanian sir. So he's been working in Shankar Eye Hospital as a senior consultant in the Department of Cornea Refractive and Cataract Surgery. So he has immense experience in the field of cornea, keratoconus, as well as keratoplasty and ocular surface diseases. So sir, kindly take over.
Good morning, everyone. At the outset, I'd like to thank Dr. Sanjana and KSOS for giving me the opportunity. So I'll be talking on C3R in thin corneas. Dr. Sanjana has very nicely spoken about the C3R treatment, which was introduced in 2003 mainly to as a minimally invasive procedure to halt the progression of keratoconus. She also spoke about the Dresden protocol, but one of the major prerequisites is that the corneal thickness should be 400 after epithelial debridement. Now, what they have shown is that 25% of the patients have pachymetry less than 400 at initial presentation, and most of the time in India, they present late. And the risk of doing CXL in such patients is that it can lead to significant decrease in the endothelial cell count and the stromal scarring. And Wollensak has shown clearly that anything beyond 0.37 milliwatts can cause toxic damage to the endothelial cell layer. Now, there are various modifications that have been spoken about. The main thing is we can either preserve the epithelium in the form of a transepithelial CXL, or you can leave a small skirt of the epithelium around the area of the thinnest pachy, and then you can also do the iontophoresis assisted cross-linking, or you can do a stromal augmentation in the form of hypoosmolar riboflavin. You can use stromal lenticules, which we get from post-SMILE, or you can do a contact lens assisted CXL, and even FILI or the femtosecond, the intrastromal lenticle implantation, or the new concept of the adaptive fluence. The essential thing that we need to understand is that we need to keep enough distance of the endothelium from the UV rays that are focused on the corneal surface. Now, coming to the transepithelial CXL, it is a CXL done where the epithelium is not removed, basically to reduce the chances of postoperative pain, infectious keratitis, and stromal haze. Now, the challenge of this procedure was that since the riboflavin is high molecular weight, it does not penetrate intact epithelium. So we need to use penetration enhancers like EDTA and BAK. And riboflavin soaked in the epithelium alone would cause attenuation of the CXL effect and even inadequate stromal concentration of the riboflavin. And the depth that we get is much shallower as compared to the original Dresden protocol. And even the studies, the biomechanical and histopathological studies have clearly shown that the biomechanical rigidity that we get is only 1/6 of the original Dresden protocol. Coming to the hypoosmolar riboflavin, so we temporarily induce the swelling by removing the dextran component from the riboflavin solution. Here it is the epi off. So the isotonic riboflavin is put on the eye for half an hour, after which an intrapachymetry is done. If the pachy does not reach up to 400, then we keep using the hypoosmolar riboflavin every 20 seconds till the pachymetry comes to 400 and above, and then the routine CXL is done. Now, studies have shown that the cornea can swell up to even 110 microns following the hypoosmolar application. It effectively halts the progression. But the thing is, as compared to the original protocol, the efficacy was slightly lesser. The reasons what attributed was they said that the stromal protoglycans absorb this the solution, and it forms collagen-free lake, and it reduces the number of collagen fibrils available for the CXL. And because of the stromal hydration, there is a diffuse the lower oxygen transport, thereby reducing the efficacy of CXL. Now, this technique was popularized by Dr. Susan Jacob, where she used contact lenses soaked in riboflavin to artificially increase the corneal thickness. And what she used was a UV barrier free, which is around close to 100 microns. It was soaked in the riboflavin solution at least for half an hour, after which it was placed on the cornea, following by which the cross-linking was done. But the drawback of this was that most of the times the riboflavin would be trapped in the supracorneal space. The absorptive property of the contact lenses was different from the corneal tissue. There was inability to customize the thickness of the contact lens, and there would be also buckling of the contact lenses during the procedure. Now, to overcome this, Dr. Mahipal came up with the novel idea of using refractive lenticules, which was obtained from from SMILE patients. So they used only the lenticles from patients with myopia, which is around 100 to 800. It was in the thickness of 80 to 100 millimeters, which was stored in MK media and subsequently shifted to the OR for the surgery. The lenticules was placed on the deepitalized surface, and care was taken to keep the thickest part of the refractive lenticule over the center of the thinnest point. And then it was confirmed by the pachymetry followed by the conventional C3R. So in the study, they showed that there was a topographic stability at 6 months. The specular did not show any significant endothelial cell loss, and they got a demarcation line at around 280 to 300 millimeters, but long-term studies are needed. Then Dr. Sri Ganesh came up with another concept of femtosecond intrastromal lenticular implantation called as the FILI, where he used lenticules of known diameter and thickness, which are again obtained from following SMILE patients. And from the lenticule, they chose around 6 millimeters to 7 millimeters. They made a small donut-shaped tissue where they removed the central 3 mm with a punch, and then the tissue was soaked in the riboflavin dye. Then they used the Visumax femtosecond platform to make a depth of around 100 microns with around 7 to 8 millimeter diameter and a 4 millimeter superior incision, and injected around 0.25 Webex extra dye into the interface for around a minute, after which they inserted the lenticule through the 4 millimeter superior section, and they used this energy of 30 milliwatts per centimeter square for 3.3 minutes, delivering a total fluence of 6.3 joules per centimeter square. They also in their group showed improvement in the uncorrected visual acuity. They showed flattening of the mean keratometry, especially at the 3 and the 5 millimeter zones. And they also showed a demarcation line in the average of around 210 plus minus 11 microns in range of 3 months. Now, this is the newest concept which people have started using, the individualized cross-linking or the fluence adaptation, where he called it as the sub-Hephazy, called it as a sub-400 protocol, where he changed the fluence based on the thickness of the cornea. So in this procedure, what he did was he removed the epithelium. He used the soaking time of riboflavin for around 20 minutes. Then he checked the intrapachymetry to look at the thinnest location, and then he used the nomogram based on the thickness. And in his study, he showed more than 90% people improved tomographic stability at the age of 12 months after surgery, and there was no endothelial decompression that he saw. So to conclude, there are various modifications to the conventional protocol that has been used, especially in thin corneas, to mainly avert the major problem of endothelial damage. Long-term studies are still required for us to come up with a proper way of managing such patients. And the way to go right now is the adaptive fluence to correct the customize the CXL based on the corneal thickness. Thank you.
Thank you, Dr. Anand sir. That was a wonderful talk on pushing our boundaries to go beyond the conventional collagen cross-linking to help patients get a better strengthening procedure.